Dear students, today I'm going to talk about some principles in cardiac surgery. Cardiac surgery is regarded as a difficult surgery. Why? Because it's a moving organ, contains blood. You know that each minute about 5 liters of blood will be pumped by the heart to be distributed all over the body. And it's vital and no place for mistakes, shared with anesthetist. So when we do surgery on the heart, this means that the anesthetist also should take care about the events and the situations that occur during the cardiac surgery. And it's very, very sensitive to electrolyte derangements. For example, and the most common one is being put. Approach in cardiac surgery, the main and commonest incision for cardiac surgery is median sternotomy, but others can be used. So median sternotomy is the main incision that's used for most traditional cardiac surgery all over the world. But others can be used like right or left anterior lateral thoracotomy, left posterior lateral thoracotomy, minimally invasive cardiac surgery, endoscopic approach, and also clamshell incision. Clamshell means a transverse skin incision, usually below the breast in females, and on both sides we do a transverse incision, and we open the skin and we divide the sternum to expose it. This is a median sternotomy. This is actually a very big incision, median sternotomy used in cardiac. This is anterior lateral thoracotomy. This is small anterior lateral thoracotomy. Usually this one is used in cases of minimally invasive. And this is robotic and endoscopic type of approach. Cardiopulmonary bypass is the main, this is the tool that's used during cardiac surgery, that's to keep the heart, to make the working on the heart easy, and at the same time to maintain the perfusion of organs and oxygenation of blood. So bypass the right and left side of the heart. We can do by cardiopulmonary bypass also thermal regulation. We will regulate the temperature of the patient, what degree temperature. Later on I'll discuss about the significance of regulating the temperature during cardiac surgery. And it's also used for oxygenation, and sometimes we may use it for filtration, for example, as a sort of dialysis. So the use of cardiopulmonary bypass during cardiac surgery, it will give a bloodless field for the surgeon. Veno-venous bypass, sometimes we may do in liver surgery to bypass the liver, venous blood in the liver, portal veins. In treatment of hypothermia, sometimes we use it, cardiopulmonary bypass in profound hypothermic patient who has been exposed to cold weather, to rewarm the patient. Sometimes in asystole, when there is cardiac arrest, we may use it to perfuse, to maintain perfusion of other organ. It may be used as an assisted device for the ventricle, and sometimes for those patients who have a damaged lung, we may use cardiopulmonary bypass in the form of ECMO. ECMO that's used not instead of heart only. This way is used for oxygenation of the blood, and we bypass the lung. The rationales for the use of cardiopulmonary bypass during open heart surgery. Cardiopulmonary bypass provided the surgeon with a clear field, as we said, that we can open the heart, even the chambers of the heart, without being jeopardizing the life of the patient. And we keep pulmonary perfusion, that's to maintain oxygenation and hemodynamic stability. We can perfuse other organs of the human body without jeopardizing the blood supply. The objective of heart lung is to provide enough flow to maintain sufficient cardiac index for tissue perfusion. The addition of cardioplegia allows the surgeon to work in a motionless and bloodless field. So cardioplegia is a solution that we use during cardiac surgery to arrest the heart. We will stop the heart because we make it motionless, and working on the arrested heart is much easier than in a beating heart. The addition of hypothermia to cardiopulmonary bypass has been standard practice since Bigelow demonstrated and proved tolerance of the entire organism to ischemia accompanied by hypothermia. Bigelow was a surgeon, and he showed that lowering the temperature of the human body will reduce the metabolic demand of the body, and by lowering the temperature, the tolerance for ischemia by the organs of the human body will be much. The cardiopulmonary circuit composed of the following. There is a venous conduit which drains blood. So we know that venous blood is usually comes from superior vena cava, inferior vena cava to the right side of the heart, and from the right side of the heart, right atrium, which acts as a reservoir. It will be pumped into the right ventricle, and from there to the venous, to the pulmonary circulation via the main pulmonary arteries, divided into left and right main pulmonary arteries. And later on, the oxygenated blood will be oxygenated in the lungs, and oxygenated blood will return to the heart via the pulmonary veins to the left side of the heart. So we put a cannula into the right atrium, which drain both the SVC or the SVC and IVC, inferior vena cava, superior vena cava, both of them. It will drain, and this drainage will be passed via a conduit, via a circuit into the into the cardiopulmonary bypass system. Sometimes we may put separate IVC cannula or SVC cannula. SVC means superior vena cava, IVC means inferior vena cava. So, and this blood will be drained into a reservoir in the cardiopulmonary bypass system, and this reservoir contains fibers that oxygenate the blood. So, this oxygenated blood will be returned into the human body via a conduit, a tubing system, and this tubing system will be connected to the aorta to be distributed all over the body. This oxygenated blood will be distributed again all over the body, and this will allow perfusion of human organs, especially the brain, the kidneys, and the liver. So this tubing system composed of a venous cannula draining blood into a reservoir, and from this reservoir blood will be oxygenated and will be returned back to the human body through the aorta. This is arterial cannula, through an arterial cannula, and the pump of the perfusion system, or the cardiopulmonary bypass system. There are head roller pumps which pump the blood instead of the heart. So by this cardiopulmonary bypass, what we do, we bypass both the lungs and the heart. So this is how the circuit will work. This is the right side of the heart. This is the left side of the heart. This is the aorta. This is the SVC, IVC blood will come into the pump oxygenator, and this oxygenated blood will be returned to the human body through the aorta by cannula. So the sites of arterial cannulation may be in the ascending aorta, arch of the aorta, right subclavian artery, femoral artery. Sometimes SVC can be used to perfuse the brain, and sometimes for de-airing. So components of cardiopulmonary circuit: venous drainage, maybe bicaval, as I said, that we can put separate cannula both in IVC and SVC. This is separate bicaval cannula. Or we may put a single cannula in the right atrium. It's called double-staged cannula. We have a reservoir, we have a pump prime. In the cardiopulmonary bypass, we have to prime the tubing system that should contain some sort of fluid. There is no place for air in this circuit, because you know that if air returns into the systemic circulation, it may embolize. It's a foreign body. It may embolize into the brain or other organs and lead to ischemia. So this prime is made of a balanced salt solution, for example, Ringer, colloids, mannitol, bicarb, heparin. So this tubing system is foreign to the human blood, and it may coagulate if we don't give heparin. So oxygenators, we have bubble or membrane oxygenators. These are two special types of, we usually use membrane type in the oxygenator. And we have heat exchanger to change the temperature of the patient. We have arterial inflow, cardiotomy sections, because when we open the pericardium and we open the great vessels, we can suck the draining or suck the blood, which may occur during cardiotomy. I mean, opening the chambers of the heart. We can suck the blood and we can return the blood back into the into the cardiopulmonary bypass. By this, we cannot lose any sort of blood. So ventricular venting, and we can put filters, of course, to filter foreign bodies, for example, oil particles, fat particles, and so on. So this is the venous cannula. We put it in the right atrium. This is the arterial cannula. We put it, for example, in the ascending aorta. This blood, it will drain blood from the right atrium, and it will go into the reservoir, and from the reservoir will be oxygenated. From the reservoir it will come into a pump, and this pump will be oxygenated through this filter to this will reduce bubbles and so on. So steps of cardiac surgery with the use of cardiopulmonary bypass: we have to heparinize. As I said, the blood will touch foreign surface, so it may coagulate if we don't heparinize. And we have to insert the cannula, connect to lines already prepared, go on bypass, demand for required temperature, cross-clamp the aorta, give cardioplegia. When you, of course, by arresting the heart, we will reduce the metabolic demand of the heart by about 90%. So when we cross-clamp the aorta, we have to give some sort of cardioplegic solution which arrests the heart to reduce the metabolic, because cross-clamping the aorta will reduce or stop blood from going into the coronary arteries and supplying the heart, coronary arteries which supply the heart. We have to do the procedure, and if we finish the procedure, no more plegia can be given. We can start the rewarming of the patient, and we have to remove the cross clamp. And surprisingly, after removal of the cross clamp, immediately the heart will revive and it will start beating. So after proper completion of the procedure, we can reduce the cardiopulmonary bypass. For example, if we calculate the body surface area of the patient. For example, this patient needs 5 liters per minute, 5 liters. So cardiopulmonary bypass machine will give 5 liters of blood per minute. If we start gradually from reducing or separating the patient from cardiopulmonary bypass, we reduce the flow of the cardiopulmonary bypass to 4 liters. And so 1 liter will be achieved by 1 liter of cardiac output will be achieved by the heart itself, and 4 liters by the cardiopulmonary bypass. And we will monitor the hemodynamic stability of the patient. If everything is fine, we can reduce the cardiopulmonary bypass pumping into, for example, 2 liters, and we see the hemodynamics. So at that time, if it's 2 liters by the cardiopulmonary bypass, so 3 liters by the heart. If we see that the heart can tolerate and can maintain hemodynamic stability, so we can reduce the cardiopulmonary bypass flow by liter until we stop it, and to see the hemodynamics of the patient. If everything's fine, so this means that we can easily stop the cardiopulmonary bypass, and the mission will be accomplished, and the heart can take care of the cardiac output. So after that, we can remove, and we will reverse heparin, that dose of heparin that we gave. We'll reduce the heparin that coagulation can occur. This will be monitoring during cardiopulmonary bypass. This coordination between the perfusion, the person who manipulate and who work on the cardiopulmonary bypass, and the anesthetist, includes monitoring of the perfusion pressure, venous return, urine output, temperature. Perfusion pressure should be above 60 millimeter mercury. Perfusion pressure is equal to mean arterial pressure. So human body can tolerate arterial pressure from 60 to 90. So we have to keep perfusion pressure between 60 and 90. Venous return, sometimes we put the cannula, maybe the size of the cannula very small. So the size of the cannula is small, so the venous reservoir will empty if we give 5 liters of blood into the arterial system. So this proper venous cannula size should be selected, that the venous return is equal to the output and the pumping by the cardiopulmonary bypass. Urine output, this means proper perfusion of the organs. So temperature is also important. We have to, sometimes some procedures need temperature as low as 20 or 18, or sometimes between 30 and 20 temperature we can, according to the length of the procedure. So blood gas should be hourly monitored, electrolytes as well. ICT, that's clotting time. We monitor the effect of heparin by measurement of ICT, activated clotting time. Activated clotting time. Sometimes you know that the heparin effect may last for 1.5 hours. So every hour we have to repeat this ACT. That's to prevent clotting in the tube system. Packed cell volume, gases in the blood, in the arterial blood, ECG activities, if any, time for the plegia. Every 20 minutes we have to repeat. Every 20 to 30 minutes we have to repeat the cardioplegia, because this is the effect of cardioplegia. That is the length of the cardioplegia effect. TEE and presence of air in the heart. Sometimes if the heart contains air, especially if you open a chamber, this air may embolize into the brain and cause problem for the patient. EEG in some cases of circulatory arrest, electroencephalography, because we need circulatory arrest. When we reduce the temperature to 18, we have to have an silent EEG, because if there is any activity in the brain, so our time of ischemia may be reduced, and we have to make the EEG silent, because this, at that point, the brain can tolerate non-blood situation for about 40 minutes. Hypothermia principles. Generally, during bypass for the cardiac surgery, there will be alteration in the blood pressure and decrease the tissue perfusion. To overcome this problem, body temperature is lowered to decrease the metabolism and to prevent hypoxic tissue damage. Most important tissues need to be protected are the brain and the heart. This is explained and applied through the rule of Q10, meaning by decreasing the temperature of the body by 10 degrees centigrade lead to decrement of metabolic rate by about 50. Hypothermia, we have two techniques. Hypothermic low flow bypass and deep hypothermic circulatory arrest. In this situation, circulatory arrest. In the previous hypothermic low flow bypass, we keep flow through the circuit, and we perfuse the human body, but according to the temperature. For example, if an adult in temperature of 34 or 37 degrees centigrade, an adult can need 5 liters of cardiac output, but if we reduce the temperature to about 20, at that time probably 1.5 liter will be enough to maintain metabolic activity and enough perfusion of the body organs. In deep hypothermia circulatory arrest, the circulation will be stopped totally. And in this situation, temperature will be reduced to about between 15 and 18 degrees centigrade. And in this situation, the brain, which is the most sensitive for hypoxia and hypoperfusion organ, can tolerate about 40 minutes of total circulation. Total circulatory arrest usually during repairs of great vessels and certain congenital heart lesions. Involves complete for example, large vessels, for example, the arch of the aorta. You know that the brain vessels that supply the brain tissue, they arise from the arch of the aorta. So when we do some sort of surgery in the arch of the aorta, we have to stop blood supply to the brain. So in this case, we use total circulatory arrest. Vital to ensure profound hypothermia should be about 15 degrees centigrade or between 15 and 18 degrees centigrade, as well as a decreased cerebral oxygen metabolism. Corticosteroids, mannitol, thiopental, phentolamine may be used to reduce the metabolic activity of the neurons, as well as to speed cooling. Complete EEG silence is cardioplegia. It is a solution of dextrose and potassium. The elevated levels of extracellular potassium increase the transmembrane potassium gradient. This inhibits cellular depolarization of myocardial muscle cells, thus preventing myocardial muscle contraction. Another type is blood cardioplegia. We can give the high concentration of potassium in the blood. Cardioplegia inhibits myocardial muscle contractility. However, this will be reversed over 15 to 20 minutes by unique ability of cardiac muscle to utilize the anaerobic pathway to produce high-energy phosphate for muscle contraction. As a result, cardioplegic solution must be administered periodically to prevent contraction. So, routes of giving cardioplegia: we may give antegrade through the root of the aorta. This will be distributed through the coronary arteries to the muscles of the myocardium. Retrogradely through the coronary sinus. Coronary sinus is the main venous drainage of the heart. Direct ostial after aortotomy, when we open the aorta and we apply cross clamp to the aorta. At that time, we have to open the aorta, and the ostium of the coronary, for example, left main coronary artery and the right coronary artery, we can directly give these routes. And thank you.